Hello, this is Lauren Pena from Cincinnati Children's Hospital in Cincinnati. Welcome to this educational activity for Pompe disease. So Pompe disease is an autosomal recessive disorder that leads to the GAA enzyme deficiency and ultimately to lysosomal glycogen accumulation. There will be accumulation in the cytoplasm as well as in the lysosomal compartments of the cells, and that's going to lead to clinical symptoms that are related to impairment of the function of striated muscle cells and the motor neurons. And so some of the clinical manifestations will be cardiomyopathy, will be respiratory insufficiency, low muscle tone or weakness, and CNS manifestations as well. There's a pretty fundamental delineation of clinical Pompe disease, and we generally think of the disorder as having infantile onset versus late onset Pompe disease. So for infantile onset Pompe disease, usually we have progressive weakness that can manifest as feeding intolerance or difficulty with feeding and respiratory difficulties pretty early on in life. There can be this muscular hypotonia and axial muscle weakness, and then there can be peripheral nervous system complications as well. And some of the vital functions that are affected can be the heart function as well as respiratory function, and it can lead to death if untreated. So this represents significant challenges to quality of life as well as survival for the patient, but also for the family and the caregivers, with frequent medical visits, hospital admissions, difficulties with treatment and care delivery in the home. There is time needed for additional medical and care needs for the child. There's a financial impact of treatment and the cumulative care costs related to complications of the disorder. There's, of course, the emotional impact of caring for a child with Pompe disease and significant anxiety. And then, of course, for children of school age, there can be difficulties with access to additional support and accommodations for the child's academic and emotional development. So the diagnosis of Pompe disease can be a combination of clinical presentation as well as laboratories that become available during the evaluation. So prior to newborn screening, many of the patients were ascertained when they were already symptomatic, and that can include cardiac symptoms with enlargement of the heart, outright cardiomyopathy, congestive heart failure, or arrhythmias. Because the patients would have diaphragmatic weakness, there would be respiratory distress or respiratory insufficiency and frequent infections because of an inability to move secretions effectively. Patients can have gross motor delay secondary to hypotonia. They can have delayed developmental milestones as well. Because of these feeding difficulties, patients can have failure to thrive. They can have enlargement of the tongue as well, and that can be an obstruction, an effective obstruction for feeding. And then they can have hepatomegaly. Some of the labs that traditionally we would use to steer us in a particular diagnostic category would be a chest X-ray, EKG, and echocardiogram to assess for cardiomyopathy or arrhythmias. We would use laboratory markers such as the creatine kinase, liver enzymes, and LDH for a nonspecific cell destruction index. And we also, if we're already thinking about Pompe disease, then we might check urine HEX4 as a biomarker of increased glycogen content in muscles in Pompe disease. The diagnosis, though, is made by a combination of GAA enzyme deficiency along with DNA testing, looking at the GAA gene and looking for mutations in the gene. Nowadays, many states are screening for Pompe disease in their newborn dried blood spots. And so we're able to pick up patients pretty early on by newborn screening. And that's been a tremendous advancement in terms of our ability to avoid the diagnostic odyssey for patients, have the opportunity to start enzyme replacement therapy as early on as possible when it's appropriate. Late onset Pompe disease, as I mentioned, is characterized by a later age of presentation and infrequent cardiac symptoms. And so usually we take symptoms to start at 12 months of age or later, and usually into adulthood. and the chronic course of the disease may progress to significant motor disability and respiratory insufficiency. And so, in many ways, we have this triangle of clinical symptoms of muscle weakness, respiratory failure, fatigue, muscle pain, and exercise intolerance, along with elevations in creatine kinase as evidence of muscle breakdown. So, a diagnosis of late onset Pompe disease can be challenging. The first reason is that there can be varying levels of residual GAA enzyme activity, and that might correspond to a wide spectrum of phenotypes. There's also a wide spectrum of symptoms and clinical presentation, and that can be quite variable in terms of age, severity, and the rate of progression. So it's really tough to have a prognosis on a patient based on their symptoms and their age. Some of the clinical presentations in late onset Pompe disease can include progressive limb girdle weakness, axial and proximal muscle weakness. There can be scapular winging. There can be respiratory insufficiency, and this is partially due to diaphragmatic weakness. And then there can be this exercise intolerance and fatigue. And some of the laboratory findings can overlap with the findings for infantile onset Pompe disease with elevations in the creatine kinase levels. And this could actually precede the onset of symptoms. There can be elevations in ALT and AST and the lactate dehydrogenase. And then there can be a reduction in GAA enzyme activity. As I mentioned, whenever there's a reduction in GAA enzyme activity, one must also have DNA testing. And sometimes that can be very helpful in terms of categorizing a case as late onset Pompe disease and also being able to review other cases in the published literature to see what the rate, age, and severity of progression might be. But be that as it may, newborn screening programs are actually permitting earlier detection and diagnosis of late onset Pompe disease, particularly in the pre-symptomatic stage, and then in that way allows us to follow the patients over time and then determine when the right time is to start treatment for the Pompe disease. So, as you can imagine, management of late onset Pompe disease requires a multidisciplinary approach. And that could include a genetic and metabolic specialist, a cardiologist, a neurologist, a pulmonologist, primary care physician, and that might be an internist or a pediatrician, a neuromuscular specialist, or orthopedist for any kind of contracture and other joint issues. And then, in support of all the providers, there might be a metabolic dietitian, a respiratory therapist, a physical therapist, an occupational therapist, speech therapist, psychologist, because we can't underestimate the disease burden on these patients and their families, a genetic counselor, a nurse, and a pharmacist. So, enzyme replacement therapy has really helped patients with Pompe disease. Initiation of ERT in infantile onset Pompe disease cases has reduced the risk of death dramatically and the risk of death or invasive ventilation dramatically since its approval in 2006. For patients with late onset Pompe disease, there's been a change in their functional outcomes when treated with enzyme replacement therapy. And this has translated into improvement in the 6-minute walk test or stabilization of the pulmonary function. And so the specific enzyme replacement therapy that is currently approved for Pompe disease is L-glucosidase alpha. And it's approved for both late onset and infantile onset Pompe disease, including patients who are younger than 8 years. Now let's go to CRIM status. So CRIM essentially refers to the endogenous GAA protein that is produced by most patients with Pompe disease. And it's essentially a Western blot-based assay to detect whether the patient can make enzyme or not. And this is an important key predictor of the clinical response of ERT for a patient. And so in general terms, those who are CRIM negative have no residual GAA enzyme activity. And what that means is that, in a nutshell, their bodies have not seen anything that looks like GAA enzyme because they just don't make it. And so once we introduce enzyme replacement therapy and a therapeutic protein, then those patients are going to recognize the therapeutic protein as foreign and are going to develop a high level of antibodies against this enzyme replacement therapy. And that will eventually reduce the efficacy of ERT. Whereas for those who are CRIM positive, their bodies have had a thymic education because there is endogenous GAA enzyme produced. And so they're going to be immunologically tolerant of recombinant GAA, and they tend to not mount as high of a response as an early response to ERT as those who are CRIM negative. And so we speak of CRIM status in patients who have infantile onset Pompe disease. We don't talk about CRIM negative status in late onset Pompe disease because we expect that patients with late onset Pompe disease will have some residual enzyme activity and will be CRIM positive. It's the patients with infantile onset Pompe disease that we really have to be very careful about determining the CRIM status because that's going to lead us in different paths before we start enzyme replacement therapy. And so for those who are CRIM positive, we expect that they will have had developed innate recognition to GAA. And so we would start enzyme replacement therapy. There are some emerging thoughts about some immune modulation in the high-risk patients or in patients with specific mutations. And the recommendation then is to start ERT and evaluate every month for the first months and then every couple months after that. And that would include very close follow-up of cardiac status for patients, monitoring of antibody titers for the enzyme replacement therapy, because we worry about development of high sustained titers and limitations to the efficacy of the ERT. And then for the CRIM negative patients, then what we say is before any kind of enzyme replacement therapy is started, we would start an immune modulation protocol. These are published protocols, and that would be to essentially blunt the immune response prior to and during the first few rounds of enzyme replacement therapy. There's going to be close follow-up, cardiac, respiratory, as well as antibody titers. And this is all based on healthcare supervision guidelines in the area of newborn screening for Pompe disease that were published in 2017. Then for the late onset Pompe disease, there's a different type of algorithm for follow-up and treatment. The recommendation is that if the patients are asymptomatic, and that might mean there are no objective signs, there are no objective symptoms, there may or may not be laboratory abnormalities. But there needs to be close follow-up to develop a treatment plan for these patients and to start ERT if there's any signs and symptoms of Pompe disease that emerge. For those who are deemed to be symptomatic, then that could include signs of muscle weakness, impairment of pulmonary function testing. If these are minors, then developmental delay, for example. And so the recommendation would be to start enzyme replacement therapy as soon as the symptoms are detected, and then also to follow very closely for the first year of treatment. Enzyme replacement therapy has been around for long enough to have data on long-term efficacy. And so there are a few studies that have been published for long-term treatment with L-glucosidase alpha. And one of them has to do with 68 patients who received up to 9 years of treatment as part of their participation in 2 sequential studies. And so 71% of the patients who were ventilator-free at baseline remained ventilator-free during follow-up. So that speaks to stabilization of disease. And even though there was an estimated annual decline in the predicted upright forced vital capacity prior to treatment, there was an even further reduction of this predicted reduction during follow-up. And though just a little over half of patients who were not using ambulatory support at baseline continued to maintain this independent ambulation during follow-up. And so this speaks to the stabilization of respiratory and functional parameters during the first 6 years of treatment of Pompe disease in those patients who have late onset Pompe disease. Even though those results are quite encouraging, there are limitations of the current enzyme replacement therapy, and those fall into 2 main categories. The first one is going to be impaired delivery. And so there might be limitations inherent to the anatomy. There might be inefficient transcytosis into the interstitial space. And so then that leads to poor targeting of the enzyme replacement product. And there might be development of anti-recombinant GAA antibodies that disrupt the efficacy. The recombinant enzyme is unstable at neutral pH, and that might lead to degradation and loss of the product in circulation. And there might be a sink effect. And what that means is that there is substantial clearance from the circulation by non-target tissue. That might be the liver, the spleen, the lymphatic system, and the GI tract. So there's a substantial reduction in delivery of the enzyme replacement to the muscle fibers, which are the ultimate target tissue. And then the second category of limitations are going to be the suboptimal uptakes. And so that might be the difficulties in the cellular uptake of ERT through receptor-mediated endocytosis. This is a product that is targeted to cell receptors through mannose-6-phosphate, and that can inherently limit how much of the product actually gets to the target cells. There might be limitations in the uptake by the muscle cells, which are the target, because of the recombinant product is poorly phosphorylated. And so now let's take a closer look at how ERT and next generation ERT works.
In the human body, glucose is a rich source of energy, which is either used or stored as glycogen. Most glycogen is located in the cytoplasm of the cell, but to a lesser extent, some glycogen is present in the lysosomes of skeletal and cardiac muscle cells. In a muscle cell, glucose molecules come together in long chains to form glycogen. Once inside the lysosomes, the enzyme acid alpha glucosidase, or GAA, cleaves the glycogen chains. A deficiency in the GAA enzyme level leads to an accumulation of glycogen in the lysosomes. This initially causes the lysosomes to swell, impairing cellular processes and damaging cell structures. Eventually, the lysosomes may rupture and release their contents into the cytoplasm, further damaging the cell. The current enzyme replacement therapy, L-glucosidase alpha, enters the body via an intravenous infusion, then binds to mannose-6-phosphate, or M6P receptors on the cell surface to form a complex. This L-glucosidase alpha M6P complex is then internalized into the cell. The complex then dissociates and the receptor cycles back to the cell surface, while L-glucosidase alpha proceeds to the lysosome. Inside the lysosome, L-glucosidase alpha breaks down the accumulated glycogen into glucose. L-glucosidase alpha enters the body via an intravenous infusion, then binds to M6P receptors on the cell surface to form a complex. This L-glucosidase alpha M6P complex is then internalized into the cell. The complex then dissociates and the receptor cycles back to the cell surface, while L-glucosidase alpha moves to the lysosome where it breaks down accumulated glycogen into glucose.
There are several products that are under development as second generation approaches for treatment of Pompe disease. And the first one of those is alpha-glucosidase alpha, and there's a phase 3 trial called COMET. The efficacy and the safety of alpha-glucosidase alpha and development of this treatment for Pompe disease was compared to the standard of care alpha-glucosidase alpha in 100 treatment-naive patients with late-onset Pompe disease. And the patients were randomly assigned 1-to-1 to receive either the investigational product, alpha-glucosidase alpha, or the standard of care product, alpha-glucosidase alpha, and that was administered intravenously every 2 weeks. The primary endpoint was the effect of alpha-glucosidase alpha on respiratory muscle strength measured by the predicted forced vital capacity in the upright position as compared to alpha-glucosidase alpha. Some of the secondary endpoints that were assessed were the safety and the effect of alpha-glucosidase alpha on the 6-minute walk test, the mean inspiratory pressure, the mean expiratory pressure, handheld dynamometry, the QMFT, and the HR quality of life, or the SF-12 as commonly known. Some of the results for the phase 3 COMET study were a primary endpoint in respiratory function that was met as measured by the forced vital capacity percent predicted, and there was substantial improvement from baseline to week 49, and that effect was 2.43%. In terms of secondary endpoints, there was a 30-meter improvement from baseline in the 6-minute walk test. The overall change from baseline at week 49 in the percent predicted forced vital capacity for alpha-glucosidase alpha was 2.89 when compared to 0.46 for those who were in the alpha-glucosidase alpha group. In terms of safety, both arms were evenly matched for treatment-emergent adverse events that were reported in the participants either on the alpha-glucosidase alpha arm or the alpha-glucosidase alpha arm. There are other emerging therapies for Pompe disease. One of them is ATGAA. This is a combination product that's composed of a novel recombinant enzyme replacement therapy, that's ATB200, and it has a high mannose-6-phosphate content, and it's co-administered with a small molecule pharmacological chaperone, AT2221. And the idea here is to stabilize the enzyme replacement therapy to maintain enzymatic activity at neutral pH during the dosing. So other emerging therapies are gene therapy, and that's an approach that is gaining significant attention based on recent successes in other disorders. There are multiple approaches that are being contemplated, including ex vivo and in vivo approaches. One of the studies for gene therapy is SPK 3006 for late onset Pompe disease. That's the phase 1/2 study Resolute. And then AT845 for late onset Pompe disease, and that's phase 1/2 study Fortis. So some of the potential roles for the next generation ERT is to address the unmet needs of patients and the limitations that are inherent to the recombinant enzyme replacement therapy. So that might include improved targeting to the lysosome and then also a greater effect of the therapeutic approach because of the improvement in the targeting and also improved glycogen clearance from lysosome and also from cytoplasm. And in this way to try and improve the clinical outcomes for the patients who receive this therapy. So in summary, Pompe disease is a debilitating and potentially fatal disease. The development of enzyme replacement therapy over a decade ago represented a breakthrough in the management of the disorder, especially for those with infantile onset Pompe disease, and particularly has improved survival for these patients. But over 10 years in, we know that there are unmet medical needs. Next generation enzyme replacement therapy promises to overcome some of these limitations by different approaches that can include enhanced targeting of the mannose-6-phosphate receptor, improve enzyme uptake by the target organ, and increase glycogen clearance at the target organ, resulting in better efficacy for many patients with Pompe disease. And gene therapy also is in development and holds potential to change the treatment of Pompe disease by very similar mechanisms.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.